Hello, everyone. I apologize for the 2-minute late start. We had some technical issues. We've had some Zoom issues here. And so I'm happy to see everyone. I'm going to keep letting people in and we will get started here in just a minute. We have a few people who are struggling a little bit with the waiting room, so I just want to make sure we can get in those who are trying. My name is Cindy Manginelli, and I'm the Director of Community Engagement here at the National Healthcare for the Homeless Council. Thank you for your patience. We've had a little bit of Zoom issues. I'll just be honest and say I hosted a Zoom meeting last evening and our account was hacked and very suddenly material appeared that was extremely unauthorized. And so I typically disable the wait. And so it happened last night, pretty late. The last meeting ended like at 6:30 p.m. Central Time, and we still haven't quite figured out. We use all of the Zoom recommended, all of the virtual meeting recommended protocols. And so technically that should have been impossible. And so I'm still a little bit cautious about making sure everything works because I'm not sure why that happened last night. So I am keeping the waiting room engaged for that and being extra cautious until we kind of figure out what happened last night. But we are really glad that you're able to join us today. This is our Lunch and Learn on the Go series. And so we are featuring every Thursday at what is lunchtime for us. I'm calling from Nashville. So it's 12 Central, a different mobile unit, a different group that's in one way or another practicing mobile healthcare, delivery mobile healthcare services. And so we are super excited about this series. This is the first in this series, and we will be doing this for the next, we'll be doing 4 weeks total. If you have any questions about this or we would love this to be interactive. So I would encourage you to use the chat, to raise your hand. We would love for you to be able to kind of explore what we're talking about today and ask questions and throw things out there, even throw things out there for discussion. We really want this to be something where everyone can kind of join in. And then if after the session is over, you have questions, comments, you want to talk more, we're happy to provide technical assistance around this as well and answer any questions that we can or connect you with those who may be more helpful. So I'm going to put my email address in the chat so that you can do that. If you're not familiar with the National Healthcare for the Homeless Council, we are a national training and technical assistance program. And we do education, advocacy, policy, we do webinars, publications, all kinds of things at the intersection of healthcare and homelessness. And so I would encourage you to check out our website, NHC, National Healthcare for the Homeless Council. I'll put it in the chat and you can see all the resources we have there around mobile health and lots of other things at the intersection of healthcare and homelessness. We are also really grateful to be partnered with the Mobile Healthcare Association. I would encourage you to definitely check out their website as well for a ton of resources specific to mobile health. And then we really appreciate our partners at the Leon Lowenstein Foundation who are funding this work. And all of the mobile healthcare stuff, you may have seen our safety and security sessions we did in September. We did something around billing for services in October, and now this Lunch and Learn, and they have graciously funded all of that. So we are going to go ahead and get started here, and I'm going to turn this over to our friends from Alameda and have them introduce themselves and tell us all about the work that they do.
Wonderful. Thank you so much, Cindy. My name is Aislinn Bird. I'm the Director of Integrated Care with Alameda County Healthcare for the Homeless and a psychiatrist with our street health team. And we are located in Alameda County, which is in the San Francisco Bay Area in California. And I'm thrilled to be here today with two of our street health nurse care managers and one of our street health program managers. And we are really going to focus on our street health mobile units. And before I pass it on over to our panelist, I'm just going to give a brief history of our street health program. So starting in 2017, we launched our street health psychiatry team. And it was really based on providing behavioral health care to folks who are unsheltered in Oakland. And our team consisted of a nurse care manager, a community health worker, an intensive case manager, and myself as the psychiatrist. And we were a backpack street medicine team. So we drove around in a little car, visiting and providing services to the encampments, primarily in downtown Oakland. But we realized very quickly that we needed to expand our services offered and to really cover all of Alameda County. So in 2019, 2020, we expanded and redesigned our program. And we did this by creating teams with smaller, defined geographic areas based on unsheltered homeless density. So we utilized the 2019 point in time count, which is the biannual census count of people experiencing homelessness. And we use this data to divide up our county into different zones. So we created 14 zones all over Alameda County, and each zone has approximately 500 unsheltered individuals living there. So to cover all of Alameda County, we expanded from 1 team to 12 teams. And we also added a primary care provider. And I want to share that Alameda County is very large and geographically very diverse. So we have very urban areas with very dense, packed homeless encampments to very rural settings where people experiencing homelessness are really spread out. And to make this expansion possible, we partnered with Lifelong Medical, Tiburcio Vasquez Health Center, Bay Area Community Health, and Roots to provide and build out our street health teams. And so Alameda County Healthcare for the Homeless provided each street medicine team with about $100,000 to purchase a Sprinter van and build it out into a mobile unit. And that's what we're primarily going to be discussing today. So I'd like to pass it on over to our panelist. And if you could please introduce yourself, describe the communities where you work, and a little bit of a history of your mobile units. So I don't know who would like to start first.
I think Emily should start first.
Yeah, I can definitely start. So my name is Emily. I work with what we call Zone 3, which is in Alameda County. Our population is not as intense as the larger cities. I wouldn't necessarily call us rural, but I think compared to the bigger cities like Oakland, we could be considered rural. So I've been working with this program for 3 years, and when I first came on, we were using backpacks and our own personal vehicles to get around and really just functioning out of a backpack and whatever we could carry. And then about a year into the program, we switched to the vans. I'm very excited to be here and kind of talk about the differences that we faced with transitioning from backpacks to having much more space and privacy in the vans.
Great, thank you. Phoebe, you want to take it away?
Sure. My name is Phoebe. I'm also really happy to be here. Thank you. And I'm one of the RNs on a street medicine team. And I'm actually with Alameda County Healthcare for the Homeless. We have a street medicine team that goes out. And I came on just before, right after really, when they had organized and purchased and had the van ready to go. I didn't have to wait that long after I came aboard in the fall of 2020. So I did get a sense of a little bit of the backpack and using, passenger car vehicle going out. I'm in zone 11, which is very urban and primarily in busy, urban streets under freeways. So that's kind of our zone. It's smaller, but higher density population. So we have the ability, whether in a car or a van, to really pull up in front of the encampments and service either by foot, car, or van. But the van has really changed things, I do want to say. And just a little bit about the van itself. I'm looking at a picture, so I just wanted to put it out there. We'll talk in more detail, but it's a 2018 Ford Transit van that was sort of built out by a recreational van company. So that just gives you a sense of there's lots of differences to talk about with these vans. Thank you.
Thank you, Phoebe. Ryan?
Good morning and afternoon, everyone. My name is Ryan Wythe, and I'm the program manager for street medicine at Lifelong Medical Care. At Lifelong, we have 5 of the 14 street medicine teams. So I support all 5 teams. We cover the cities of Berkeley, Albany, Emeryville, West Oakland, downtown Oakland, and Lake Merritt. And similar to Phoebe, the areas we're serving are very urban. A lot of people who are living under freeway overpasses, on-ramps, off-ramps, medians. We have folks who are kind of like spread out into smaller encampments, but also some areas where we have some really large ones, like 150 to 200 people might reside in a particular encampment. I started on with Lifelong, and I have like a cold situation, so sorry if I'm being weird, but I started about 2 years ago, and we had 2 vans out of the 5 teams, and then 3 more came on a little bit later. We were using civilian vehicles for those teams without the medical vans to go and do outreach. And, I think that from the perspective of, just being pragmatic, not letting perfect be the enemy of the good, it's not necessarily about the vehicle, but it's about meeting people where they're at. So do the best that you can with what resources you have available to you and just start from there. We are really lucky to have the mobile units. Our mobile unit has an exam table, a little refrigerator so that we can do cold chain management for vaccines. It has a sink. But what we use the most is probably the phlebotomy station. So each of our teams has a full-time registered nurse, and we do a lot of lab draws out in the field. Lifelong is a FQHC, so our bread and butter is primary care. So being able to do those labs as part of ongoing health maintenance is really, really important to us. It's part of our infrastructure. Yeah.
Wonderful. Thank you, Ryan. Emily, you mentioned that transition from being like a backpack street medicine team to having a mobile unit, and wondering if you could talk about that transition and the pros and cons of, doing a backpack street medicine versus a mobile unit, and if you still kind of, go out just with a backpack.
So when I started, I want to say each team member had a pretty big backpack that we would carry around, and it was a struggle to not turn around and knock someone or something over. But what we did was, so we're similarly structured. So we have a nurse practitioner, a case manager, and a CHW, a community health worker. So the case manager and the community health worker, the way we tried to organize their backpacks were geared much towards engagement supplies. So having consent forms and just the basic things that we would use to start engaging with clients. And then as the nurse and the nurse practitioner, we both would have more wound care supplies. I think that is kind of the biggest thing that our clients need out in the field, for at least for our population. So making sure that we have it kind of organized so that way we can find what we need. But in reality, when you're walking around with a backpack, things get shuffled. So then we transitioned over to the vans after about a year. I would say that we still have the backpack structure. So we still keep 4 backpacks, each backpack is still filled like how it was originally. The benefit of the van for us really is the privacy and the extra storage room. So now we can carry much more as far as healthcare supplies, um, COVID tests. We also have a fridge similarly to what Ryan was mentioning, so we can do vaccines in the field. But I think for us, because we are more rural, most of our clients are located along railroad tracks and in lightly wooded areas. We can't really pull up to a camp, so we park and then we kind of switch back to the backpack mode for a little while. We go in and we triage what needs to be triaged out in the camp. And then if something requires a bit more privacy or would really just benefit from moving to the van, we encourage the clients to come if they want to. Not everybody is comfortable coming into the van because it is a closed space. And I think clients with particular trauma, they're not as comfortable, and that is definitely fair, but it's always good to have that option. So I would say that we still use the backpack method the most, and then the van is more supplemental and supportive for us.
That's helpful. Thank you, Emily. I kind of want to pass the same question on to Phoebe and then Ryan about that transition to mobile units and when you use the backpacks and when you primarily use the van.
Yeah, so again, the difference between just Emily and our zones is that it's just more urban, so a little bit more accessible. The way we have it is our van is, I would say, for those of you looking into a van or what have you, keep it simple. It is a mobile unit, so things move around and stuff, so it can't get too complex. And keeping that in mind, then that means that you want to have a quick way to grab a backpack or a bag to go into the field if you need to. And that may just be a short distance behind a fence, more further under an overpass, what have you. So we also, in thinking about without a van, less storage, obviously, and just having to think a little bit more critically about what you need from the office because you can't go back. And so with the van, more storage. So even if we have our backpacks, as Emily said, we have some room in our van. We have like a seat that unfolds and we put items in there for storage. We also have cabinets, but we also keep like a medical bag for our doctor, our primary care provider, and myself that we can carry, as well as with outreach supplies. And then, so we still have those things. So if we need to leave the van, meet the person where they're at, what have you, they're not feeling well, we need to go out and see them, we still do that. But the van has changed that in the sense that also we can provide the privacy, which one thing I want to just reinforce that I've really appreciated with the van is that oftentimes I will see a person's whole like sort of demeanor just like kind of a lift. It's really nice when they come into the van, and it's not always, it's sort of a surprise. And so I've just really appreciated that in the differences between kind of working out where do we go when we're in front of their tent or they're from front of their home versus, hey, come on in the van, and then we just start talking. So I'd say that's one of the biggest differences between the car and the van. And again, I just want to reinforce, because I think this is the bottom line, as we meet them where they're at. So that just might mean next to the van, in front of the van, down the street, what have you.
And just quickly, I see the question in the chat, but just like Phoebe said, our teams operate pretty similarly. I think one of the biggest differences was that, when the teams got the vans, they became really visible when they would roll up to an encampment. And our vans have, they've been wrapped. So, you could see street medicine, lifelong medical care. It's really obvious when you pull up. And so it created a situation where people, would start coming and lining up in front of the van, wanting to get seen or get services or get supplies, which was really different from, before we had the medical van. But people, you just make adjustments along the way. Each team has like the list of their high priority folks to follow up with at different encampments. So if you don't see them when you show up, if they're not in front of the van, you go out and you find them.
Great. Thank you, Ryan. Maybe I'll jump to these questions and then we'll come back to the panelist. So Lisa, great question about the structure of Alameda County Healthcare for the Homeless. We are a HRSA-funded FQHC, but we have a lot of contracts. You know, we can't do this work alone, and having partnerships is so key. So we did partner with different FQHCs that are based in the geographic area. So the idea is we broke up in these 14 zones, and each zone has several, each zone has its own street medicine team, and then that street medicine team is connected to a medical home in that geographic area. So again, it's meeting people where they're at, and ideally when the patient is ready, connecting them and doing that warm handoff to their medical home. And so in having those partnerships is critical, because there's no way that just Healthcare for the Homeless could do all this work. So Alameda County Healthcare for the Homeless has one team, and then like Ryan said, Lifelong has 5 teams. I think Tubercio Vasquez has 3 teams. Is that right, Emily? So it kind of depends on how the zones are broken up and where that medical home is, based on the geography. And then another great question from Joey from our EHR. And maybe I'll have the panelists answer that question about where they document. So Ryan, you kind of mentioned Epic. Do you want to share more about that?
Yeah. Lifelong had transitioned to Epic, I believe pretty shortly before I started working with them. So Lifelong is still somewhat new to using Epic, but we do use Epic. We have, I don't know how many people are familiar with Epic, but street medicine has its own kind of department within the EHR structure, so that way we can also do reporting on our patients. We can do some data dashboard development, that type of thing. So it separates out the encounters that we have in street medicine from encounters that our patients might have in other clinics or other OCHN locations.
Emily, do you want to share about your EHR?
Yeah, we also use Epic. Similar, we have the department that is designated for street health. And then that just kind of reminded me that in the van we have a computer, so that way we can chart. But like Phoebe was mentioning, the vans move around a lot, so it is challenging to secure the desktop, so that way it doesn't break. So just something to think about if you're looking into designing a van.
And just also let you know, we have social workers on each of our teams. Our social workers are also documenting in Epic their behavioral health notes, so that way you can see, kind of like the full picture of what is going on with somebody when you click into their file, for both their physical health and their behavioral health needs. We don't have a desktop installed in the vans. All street medicine teams have a laptop that they can bring out with them in the field, and we installed cradle points in each of the mobile units. So a cradle point is like having your own internet modem on the van. We have a generator on the van. The modem needs to be plugged in, so we have to turn on the generator in order to use the cradle point. But it's a really been a really convenient way for people to be able to maintain access and be able to chart out in the field if they so choose. We've used mobile hotspots before the cradle points. You don't need to be that fancy.
Phoebe, do you want to chat about our EHR?
Yeah, we have a little bit of a different situation. As far as charting, we hope to be in Epic in the next year or so. We do have access to it. Epic is great. I've used it in my previous roles. I won't go into detail about what we have right now, but we do have a way of charting, obviously. But we have access to Epic and we can communicate in there, and I can't say enough about that. And then as far as, I just wanted to follow up with what Ryan was saying, as far as like we all use laptops, but it touched a little bit on, you've got this mobile unit, it's got to be sufficient, it's got to be self-sufficient rather. and it's electricity, whether it's a generator. We actually have solar powered, which is really cool. And I just want to say, if anybody's interested in that, that just to make sure that the equipment itself, somebody knows about it. It's pretty high tech in a way. And if your mechanic in your facility, or if you don't have anybody that understands it, it becomes an issue. Became one for us. We figured it out. But I do recommend that, you know, somebody knows how to service it. So just kind of, it can get pretty wild out there with these new recreational vans and all the work that's being offered. You can get, you know, pretty technical, and again, just keep it simple. So we have a way to use outlets, which is really great. We have a way to power, you know, warm water, heat, and lights and so forth. So that's just essential.
Thank you, Phoebe. And we've touched a little bit about the design of the vans, but if you each could take some time to describe how you came up with your design of the mobile unit and kind of walk us through the different elements. Phoebe, do you want to start?
Yes, thank you. I have to admit, I wasn't around during the design. I came in after. However, what I've heard is that our a colleague that we work with, Jared Bundy, is an experienced street health nurse, and he had a big part in the design of the van, as well as David Motorsbach, who works for our organization. And the two of them really had a lot of say into the van. And one of the things that I like about it is that they thought about having a bench that can lengthen or shorten depending on the height of the person. And so it's a black bench with cushion with storage underneath, and one can sit down on it. And it's as long as like 3 people could sit closely together on it. And then you can lift up one side of it or put it down and lift up the other side. So it can hold one's feet. They can really lay flat. So that's really nice. And then also there's as Ryan mentioned earlier, with the phlebotomy station, we have an adjustable, movable, again, this comes into these recreational vans type things, but an adjustable movable table. So if one is to do phlebotomy, we can put it on the right arm or the left arm by moving the table. And as well as small procedures that the physician can do. It's been very utilitarian. It's been great. I could say more, but I'm going to pause and let others go.
Emily, do you want to discuss the design of your van?
So our van, we have a generator as well. That would be really cool to be solar paneled, but we got the generator. Very thankful for it. We have an exam table that is adjustable, so you can like elevate it. So it would be like a sitting table or a laying down exam table. Underneath, there's a nice little storage area that we've added bungee cords and made work so that way nothing is flying around while we're driving. We have a sink, we have the fridge, plenty of cabinet space, plenty of overhead cabinet space. The little, I would say that it's supposed to be a charging station, but it's just kind of like a shelf with our desktop on it that we have bungee corded to the wall so it doesn't break. And then we have the 2 front seats. It would be nice if we had a third seat, but we do not. We would have had to sacrifice the exam table in order to have the third passenger seat. Our van also does not have a phlebotomy table or like a phlebotomy setup. And then ours does not have any like wheelchair accessibility or any ramp. So that is a challenge that it would have been nice had we found a way to get something more accessible for clients that are in wheelchairs and use walkers.
Yeah, I think actually our vans were done by the same folks that did the vans for Emily's organization as well. So they're really similar, except for we do have the phlebotomy station. It's at the back of the van. So there's when you look at the van on the left-hand side, there's like a little desk We have all of our phlebotomy stuff in pull out drawers like above the desk. And then there's a chair next to the desk. There's an armrest that you can affix to the wall that will come down in front of them, so you can lay your arms out and do blood draws from either arm. There will be a sink behind you, tons of cabinet space and storage, and then there is the exam table, kind of more in the middle of the van. The exam table for us, we love actually the design that Phoebe's van has for the exam table. Ours does not get used very frequently, especially because street medicine for us has coincided almost entirely with COVID. So we were not actually seeing a lot of people on the vans for a long time. Now that we've loosened our risk mitigation measures, we are seeing more folks on the van, but not a terrible amount. I think it gets used more often for doing like point of care ultrasounds. So our teams have the ability to do that. Sometimes we'll do some lower body exams, gynecological exams, that type of thing, but not a ton.
Great. I also wanted to add, if I could, just Emily had mentioned and had heard that there is this option of having a third seat, and we do have a third seat. So I just wanted to add that in, that we have the driver's seat, passenger seat, and behind the driver's seat is a third seat, which has really been very helpful. And then in addition, the passenger seat swivels. So if you can imagine a person sitting on the bench, a person in the seat behind the driver's seat, and then the passenger seat swiveling, I hope you can follow me. It creates a circle, like a meeting circle, which is really nice.
Thank you all. And I see a question from Elisa about how your vans look like if you advertise that we work with folks who are unhoused. So if you could each describe, how the outside of your van looks.
Our wrap just says Lifelong Medical Care Street Medicine. It has our organizational logo as well as the logo of Alameda County Healthcare for the Homeless. It doesn't say anything specifically about come here, get your healthcare if you are homeless. But we had a really great graphic designer, so we have like nice, bold, punchy colors with a great little logo for street medicine, and it's very easily recognizable in the community.
Emily?
So our van, I think, is similar. It has our clinic's name, Street Health, and then there is the Alameda County Healthcare for the Homeless logo. It's great to have the visibility, but a challenge for our team specifically, and maybe the other teams as well, is that like with visibility comes negative visibility. A lot of our camps are prone to being abated and swept, and something that we were conflicted with for a long time was that by bringing attention with a giant band that says Street Health and Alameda County Healthcare for the Homeless logo, that we were drawing more attention to the clients and to the camp. So we would purposefully park further away and then backpack in. And if we needed to move the van closer, we would, but that was something that we had to consider.
Really good point. Thank you, Emily. Phoebe?
Yes. Yeah, our van just says Alameda County Healthcare for the Homeless, and it's really bright. So it's a white van, and the decals themselves are our colors, which are purple and teal. I hope I have that right. And it's very, I would say, cheerful colors, very noticeable. And I think at times I've noticed that some folks are maybe a little bit cautious in coming up to the van for that sake. But I think as people get used to seeing it more, then it just becomes part of the background.
Great, thank you. Now we're happy to email out photos and also the layouts of the vans afterwards. I see a question from Cindy about lab work and how we're able to get lab results back to our patients. Can you all address that?
Yeah, so Like Phoebe mentioned earlier, folks getting used to seeing us. So our teams operate on a proactive outreach basis. So they have a pretty regular schedule of going to the same encampments, the same day of the week at the same time of day, every week or every other week. Especially during COVID, there was a moratorium on encampment abatement. So the encampment communities that we were serving were pretty stable. It hasn't been up until the last like 6 to 8 months where we have had a lot of challenges with displacement. So getting people's lab results back wasn't, terribly difficult as long as, they were stable where they were staying in their encampment. We would see them just like the following week. And would be able to deliver those results. And also, you lose a lot of people to follow up and they don't get their results, and it is what it is.
Yeah, I would say the similar, that if we're drawing the labs, that we make a plan to come back within the week. And oftentimes they have phones and so forth, or I will make a follow-up appointment with our provider. So it's the difference between the outreach, right, and then the targeted visits. And so it may be that, excuse me, if it's a complicated lab or there is really something going on, that I might want the provider to meet with them, or I will simply, make a point of stopping and telling them the results.
Thank you. You've each kind of alluded to some of the pros and cons of having the van, and wondering, in terms of how you use the van in terms of your service model and providing care. Phoebe, can I put you on the spot again?
Sure. So the pros and cons. Well, I'll start out with the pros. We've mentioned privacy. So this has been a big thing, just to, obviously, if you're doing any procedures, injections, or talking about sensitive matters, it's just really nice. We do have a way, some vans might not even have any windows, some might have tinted windows. We have curtains that we can put up and take down. We actually have an outside awning. That's not a privacy thing, but I just wanted to make sure I said that we have an awning, and on hot days, that's made a big difference. And we don't always use it, but it does make a difference. Anyway, so the pros, privacy, intimacy, maybe sometimes a little bit of motivational interviewing, we'll kind of see where somebody can get, and it doesn't all have to be medical, like our outreach worker can meet the patient in the van's intimate setting. Able to do procedures, it's not safe to go into somebody's dwelling in their tent. We've been told not to. So if we want to get something complicated, wound care, phlebotomy, what have you, it's a little bit easier in the van. I know there's lots of providers that can do a lot of stuff on the street. So it really depends, provider dependent. But so pros, and then we can get places. We've got lots of storage. We've talked about that. Cons are a little bit of building trust with folks. May feel a little bit formal, off-putting for some folks. We mentioned a little bit that we're an announcement, so that folks just kind of line up to get outreach supplies, and we're really trying to engage people from a healthcare point of view. But that's great. We always meet great folks doing that. And then just not, I think ultimately when we meet people where they're at, that probably usually means by foot in some sort of fashion. So again, that's the ultimate, is just wanting to make sure we're doing that. That's not really a con, but we can't always get to where we want to go with it.
Thank you, Phoebe. Ryan, anything to add?
I'm sorry, this might be the cold, but can you repeat the question?
Yeah, just the pros and cons of having a van, especially versus doing like just a backpack.
Yeah, one of the things that's a huge pro is the storage. So, we have a pretty robust budget for what we call client supportive expenditures. And this is where we're buying a lot of things to meet people's immediate felt needs. So clothing, water, we get non-perishable food bags from the food bank. We give out camping supplies, tents, mats, tarps, fire extinguishers are a big one. We give out a lot of pet supplies, food, flea medicine, etc. And so being able to have a good cross-section of those things to be able to help meeting a need of somebody who you encounter in the field and provide an immediate form of comfort is probably one of the best engagement tools that we have when working with people. So so our ability to be able to have that at our disposal at any point in which is needed makes such a huge difference. Let's see, a con. I don't know. I think that like, people are gonna like make do with what they have, and it's gonna like what you're gonna be doing is gonna be dictated by the needs of the patient that you're working with. It's not necessarily if the van is good or bad. It's gonna be about how we're utilizing the resources we have available to us to be able to meet people's needs. I guess that's what I think about that.
Yeah, great point. Thank you. Emily, any pros and cons from having the mobile unit?
Definitely storage and not having to run back to the clinic because there's something that you urgently need that you didn't bring with you. But also the privacy, particularly for clients I found that might be experiencing domestic violence or intimate partner violence, having somewhere where we can really go and be away from the eyes of others, whether it be the partner or the perpetrator or just other camp members, I've found really makes a big difference for clients. And a lot of times for us, thankfully, it makes them feel more comfortable to disclose certain aspects of their private life to us. Like I said, we still mainly rely on the ability to do like a backpack van hybrid type setup. I don't think we have any camps that we just drive up directly to and pop the van open. It's always parking it as close as we can, but then getting out, grabbing the backpack and triaging in the field, and then moving clients that are comfortable back to the van if needed. And my provider and myself were both very comfortable doing a majority of procedures in the field as opposed to in the van. So it's really, like Ryan said, up to what the client wants and what they're comfortable with and meeting them where they're at. And then I would say for the cons, again, it would just be the visibility, which can be a pro and a con of like potentially ousting a secret camp to like prying eyes, or we've even had community members come up to us and like say some not so nice things about our clients and ask what we're doing and when we're going to get them out of there. And like that phrase in and of itself is just really frustrating to hear, especially when we're trying to build trust with the clients.
Great point. Thank you for sharing, Emily. And I see another question about utilizing telehealth. And if your teams call in other providers when you're out, or if you do utilize telehealth. Emily, do you want to start?
Yeah, so we do have the ability to call in, especially for podiatry. We're really fortunate to have a podiatrist at our clinic who is available to initiate telehealth encounters with our clients. And then another thing that we've been starting to use is like the doximity, but I mean, that's just really getting started for us. So I don't have much experience with it yet. And I don't know how it will translate to being in the field, but for us, the main one is podiatry, but also then we have dental, who we usually have one or two providers who can field some calls from us and help us triage and determine if we need to get a client in urgently for a dental concern.
That's great. Ryan, any thoughts about telehealth?
Yeah. So I guess one of the things is that each of our teams has a part-time advanced practice provider that will go out 3 half days per week with the teams. So, a nurse practitioner, PA, medical doctor. So from that perspective, we don't need to do a lot of telehealth, around working with prescribing providers, that type of thing. I'm super jealous, Emily, that you have like an in-house podiatrist. That sounds awesome. But Lifelong does have a pretty robust dental arm. So we have a mobile dental van that actually goes out with our street medicine teams every other week to some of our larger encampments in Oakland. And the dental van, is like a little miniature dental clinic on the inside. So we get people in for their dental stuff that way. Sometimes like our staff will help with facilitating specialist visits via telehealth, but it doesn't really come up that often. We try to shy away from telehealth just because, well, one, I think about 80% of the people, 80-90% of the people we work with don't have phones. So we would have to be present in order to facilitate that telehealth visit. And if we have to be present, then we might as well just be doing the visit ourselves for the most part. Yeah.
Great, thank you. Phoebe?
Yeah, our model and our street van is very similar to what Ryan described, in the sense that we have a primary care provider, medical provider that goes out 1.5 days a week. And a lot of it is care coordination services. We do not do a lot of telehealth, so we'll organize the dental, just as Ryan said, so I don't have to repeat that, very similar. And I think our program is unique in the sense that because we are healthcare for the homeless, we work primarily closely with one of the Lifelong clinics, the organization that Ryan's from, excuse me, but we're not a primary care clinic. So really the bulk of our work too is coordinating and finding that person a medical home. That's a big part of street health, I think. So
I will jump in that I provide psychiatric care to our team. And so sometimes I go out 1 day a week, but if I'm not able to, if Phoebe sees a patient that I've been trying to find, that, Phoebe will call me, and if I'm available, I'll meet with a patient over the phone. And so that's been a great way to connect with patients that I have been lost to follow up to behavioral health care. I see another question from Cindy. Do you dispense medications or refer patients to a pharmacy? What do you do with prescriptions? Phoebe, do you want to start?
yeah, we do both. Excuse me, my morning coffee. Yeah, we do both. So we, how do I begin this? We had the benefit of having, we have a pharmacist who's a consultant. And this pharmacist got us set up. We work very closely with a local pharmacy. They're called New Oakland Pharmacy, and they're kind of a mom and pop pharmacy. And we order medications through them in bulk. And then they label them with a label where we can write the instructions, as well as a label that we record into a binder that states that we've dispensed that. We have both, for example, antibiotics. You can have like doxycycline, write the instructions, hand it to the patient, put it in the book to record it, and then follow up with the patient in a week, 2 weeks, see if they're better. We also have, an administrative medication on site. So that might be medication, more antibiotics, for example, to treat an STI right there, or that's what comes to mind, obviously, is something like ceftriaxone to treat gonorrhea. Like we could treat it right there, and it's the same thing. We would record it in our little binder so that when the pharmacist does an audit or what have you, that we've documented it. So we do carry medications whenever there's a provider. So whether we have our psychiatrist or our medical doctor, I can carry these medications. I'm not in a position to dispense them myself as an RN at this time, but anyway, go into that later. And then obviously we coordinate a lot with the pharmacies. It's just the local Walgreens and what have you, and this local New Oakland pharmacy. And we'll pick up medications for folks that just aren't in a position to do so, with kind of the goal of maybe them getting them themselves. And for some folks, they figure that out, some don't. So we do provide that service. Again, I'm in a smaller zone, so I think it really depends on the logistics of people getting medications. But just to recount, we work closely with the local pharmacy to get our medications. We dispense them on the van when I have a medical provider present.
Great, thank you, Phoebe. Ryan, do you want to talk about dispensing medications and working with pharmacies?
I honestly don't have anything to add. We work basically the same as what Phoebe just described.
Great. Emily, anything to add?
Our teams don't carry medication on us to dispense, even with the providers present. But like Phoebe was saying, after we assess the client's ability to really go out and get their medications independently, if they need assistance, we're happy to go pick it up and deliver it to the client, but still trying to promote the client's autonomy and ability to care for themselves as much as possible.
Great, thank you. The only thing I'd like to add is that we obviously don't carry any controlled medications, but we do prescribe a lot of buprenorphine, which treats opioid use disorder. So I know that's something that a lot of the prescribers offer, and I think it's a critical service in providing MAT to folks that we serve.
I think just to add on to that, we are really trying to look at the logistics of being able to do certain long-acting injectables in the field, which, being a mobile unit does add a whole element of logistical challenges, especially in terms of cold chain management, making sure that things are being handled to the specificity of the manufacturer's instructions, that type of things. There are certain long-acting injectables that are just impossible for us to do, but others that are more feasible. And so that's just another layer around the medication piece that just came to mind.
Great, thank you. It's a really good point. I see we're almost out of time, and I was wondering if we could close with any big lessons learned or anything that you would do differently about your van, or just major takeaway points for our participants. Ryan, do you want to start?
Yeah, sure. I mean, I got into this work a long time ago, working with a small needle exchange program like 15 years ago. And when you are coming from a place where you are just making it work with whatever you have available, you learn that over time you work on continuous improvement around the resources that you provide, the infrastructure you're building. Don't let having a fancy mobile clinic get in the way of you doing the best that you can. Any positive change makes a big difference. The point is to get resources out to the people who need it the most, and providing what care and support you are capable of doing. And yeah, that's it.
It's wonderful, thank you. Emily, any takeaway points or any big lessons learned from your team?
Yeah, similar to the others, I would say keep it as simple as possible, especially if you're going from just doing a backpack method to jumping into getting a van. I think the biggest thing is you want a safe place where you can build trust with the client, and you can do that anywhere. A van just sometimes gives you an extra layer of privacy. And I think the goal for our clients is to get them into the clinic. So when we don't have the ability to provide a service in the field, that maybe in retrospect, if we had formatted the van differently, we could have done for them. It's a nice opportunity to encourage them to come in and be seen in the brick and mortar site. And by then, hopefully, we've built that trust and can support them in that journey. But keeping it simple, utilizing your storage space, and having a way to secure your belongings so they don't fly everywhere and break. All of those are very important.
Wonderful, thank you, Emily. Phoebe?
I would just, ditto everything they said. I can't really think of too much. I think it's really easy to get caught up in sort of the design and the fanciness of the van. Some things just to keep in mind. I really like what you said earlier, Emily, about accessibility. Ours too is not, there's a stair, there's a step up. We don't have a ramp, but we do have handholds. Those make a big difference. So, keeping in mind the height, that one might want to go really tall and think about overpasses and accessibility of your van and parking. Our provider, I think the tallest person that's in there is not that tall, so we're kind of lucky, but I don't know, it's not going to fit everyone. Yeah, I guess I thought maybe I had something a little bit more, but really I think you said it all. So if I have something to add, I'll jump in.
Great, thank you. This was a wonderful discussion. Actually, I learned a lot as well. So thank you all. Maybe I'll pass on over to Cindy. I know we have a few more minutes. I don't know if there's any last minute burning questions. And I will also email Cindy photos of the vans and the layout of the vans. And so Cindy, if you can, great, email that out to everyone if folks are interested. You can take a peek at our vans and the layout.
Absolutely. Thank you so much. This was awesome. I learned so much. That was I love that idea of almost kind of a hybrid model of street medicine and mobile health. And that's fascinating. That was, like I said, I learned a lot. Thank you so much. Thank you for your time today. We have a lot of people who registered who will get the recording as well. We will have the recording available and everyone who registered will receive the recording. But if you have others that you'd like to share it with, feel free to do so. We will, our next Lunch and Learn will be a week from today, same time. And we'll be really looking at a unit that's serving a significantly rural area. And so a little bit different kind of setting next week. Feel free to email me. I'll put my email address in the chat. If you have any questions, if you want to do some kind of follow-up technical assistance, anything like that, we're happy to serve in that way. I'll also send out the link to register if you'd like to join us next week. But thank you so much to all of our speakers and to all of us, to all of you who helped to make this interactive. And we kind of learned from each other today. And have a good afternoon.
Thank you, everyone.